In this PowerPoint, we're going to take a look at how OSA and sleep-disordered breathing affects or contributes to various cardiovascular and cerebrovascular disorders. Let's go to our first slide. Cardiovascular disease and OSA is more than a coexistence. Most common causes of morbidity and mortality in industrial countries include myocardial infarction, cerebrovascular disease, congestive heart failure, stroke, and cardiac arrhythmias. Sleep-related breathing disorders are increasing, and obesity is an epidemic. So we see all of these occurring together, and what this is saying is that it's more than just that they occur together. They actually are contributing to one another. Sleep-related breathing disorders, insomnia, and REM sleep can negatively affect vascular disease. So not just the OSA itself, but also insomnia, sleep deprivation, and REM sleep can contribute to vascular disease. There are several aspects of OSA which contribute to the development of cardiovascular disease. We need a basic understanding of how OSA contributes to cardiovascular disease, and by understanding how OSA contributes to cardiovascular disease, we can reduce its risk and better manage it with proven therapies. Let's go on to our next slide. Let's start with identifying how our autonomic system should function if it's normal. The autonomic system is a balance between sympathetic and parasympathetic systems. This means it's a balance between what the body needs to do to function day to day with what the body needs in times of crisis. The sympathetic portion of your autonomic system can take over the system at any time. This is your fight or flight response. When the sympathetic system is activated, it releases large amounts of noradrenaline into your bloodstream. This increases heart rate, strength of contractions, blood pressure. It also causes some vasoconstriction, which reduces blood flow to certain organs. The parasympathetic system, on the other hand, is control most of the time. This is what's maintaining homeostasis. And anytime the sympathetic system decreases in activity, the parasympathetic system is going to increase in activity and vice versa. This is your rest and digest portion of the system. It regulates the things for your gastrointestinal tract and when your body is resting. This system releases acetylcholine, which brings your heart rate down and indirectly also brings your blood pressure down. Let's go on to our next slide. Let's talk about how our autonomic functions while we're sleeping. With sleep onset, we dramatically lose our sympathetic tone, and at the same time, we increase our parasympathetic tone, because remember, they can't be on at the same time. So as the parasympathetic tone increases or becomes more activated, this brings the heart rate and blood pressure down. This continues as you go into deeper stages of sleep and into REM. With phasic REM, we do see short bursts of increased sympathetic activity. This is what causes the variability in heart rate, blood pressure, and respiratory pattern in phasic REM. Let's go on to our next slide. In this PowerPoint, I'm going to be using the term sleep-disordered breathing to refer to obstructive events such as hypopneas and obstructive apneas. I will also use OSA in this PowerPoint to refer to both obstructive apneas and hypopneas. The reason for this is because both obstructive apneas and hypopneas are considered obstructive events, meaning the drive to take a breath is there, airflow is just being blocked. Both of these disrupt normal sleep. They both affect blood gases the same way and pulmonary mechanics. Central apnea, on the other hand, this is not an obstructive event, so it will be used as a separate term throughout the PowerPoint. It is caused by different factors than OSA. It has different mechanical and physiological effects on the body overall as well. Let's go on to our next slide. Okay, so this diagram shows us how OSA is going to cause its cardiovascular effects. If you notice on the far left, it starts with OSA. OSA causes sleep fragmentation, intermittent hypercapnia, intermittent hypoxemia is what the other one should read, and intrathoracic pressure swings. Now, notice how all of these cause subsequent things. For example, sleep fragmentation causes recurrent arousals. However, intermittent hypercapnia also causes recurrent arousals. It also causes chemoreceptor activation. Intermittent hypoxemia also causes recurrent arousals, chemoreceptor activation, and baroreceptor activation. The intrathoracic pressure swings, these only affect the pulmonary stretch receptors in the lungs, and it activates those. So as we continue to move on to the right portion of our diagram, you'll see that every single one of those factors, the recurrent arousals, chemoreceptor activation, baroreceptor activation, and pulmonary stretch receptors being activated, all cause sympathetic activation. Now remember, the sympathetic system, if that's activated, it's going to release noradrenaline, which is a catecholamine, into the blood system. So what this is going to do is it reduces vagal tone. That means it turns off the parasympathetic system. It increases catecholamine release. That's your noradrenaline being dumped into the bloodstream. It reduces heart rate variability. It causes hypertension. It causes arrhythmias. It causes left ventricular failure over time and congestive heart failure. Now, how did we get from hypertension to left ventricular failure and congestive heart failure? Well, as the blood pressure is high and remains high, that puts more workload on the left ventricle to pump against that high pressure, and over time that ventricle will begin to become hypertrophic and fail, which then leads to our congestive heart failure. So in this diagram, we see how OSA has certain factors that it causes: the sleep fragmentation, the hypercapnia, the hypoxemia, and the intrathoracic pressure swings, and how all of those cause another action, the recurrent arousals, chemoreceptor activation, baroreceptor activation, and pulmonary stretch receptors activation, all of those which cause your sympathetic activation, and then that leads to your cardiovascular effects. Let's go on to our next slide. Okay, so what? What are the lasting effects for a person with OSA, and why do we care? Well, let's start with the initial effects with OSA on sleep. Initially, when it begins, blood pressure is not going to decrease during sleep as it should. The reason for this is that sympathetic activation. If your sympathetic system's being activated, then the blood pressure can't drop during sleep. What ends up happening is they become hypertensive while they're sleeping. So the initial effect is nocturnal hypertension. As this continues and as the patient goes untreated, this is going to lead to elevated blood pressure during the day. We call this secondary hypertension because it's actually due to OSA. A lot of patients' first symptom is hypertension, and they will be diagnosed with primary hypertension. This is an indication for a sleep study because, as we now see, that can be a secondary problem to OSA. So primary hypertension could be incorrectly diagnosed. If they do a sleep study and find the patient has OSA and they treat that, oftentimes they can find that the patient doesn't need blood pressure medications, they just need CPAP therapy, and their blood pressure will return to a normal level. If we do not intervene with PAP therapy and the secondary hypertension continues, eventually this will progress into left ventricular failure. That's because that left ventricle has to pump the blood against those vasoconstricted vessels. Over time, if the OSA continues to be untreated, this can develop into congestive heart failure. Interesting enough, as congestive heart failure worsens, that can actually lead to central sleep apnea. So OSA, if left untreated, can cause nocturnal hypertension, which can turn into daytime or secondary hypertension, which then can turn into left ventricular failure, and then develop congestive heart failure, which then can cause central sleep apnea and Cheyne-Stokes respirations. So that's just kind of a progression of what can happen. Let's go to our next slide. So how can PAP affect the overall situation? CPAP in hypertensive patients with moderate to severe OSA leads to a significant reduction in arterial blood pressure. So CPAP therapy treating OSA will also treat hypertension and bring it back to a normal level. This is more pronounced in patients with severe OSA. A significant reduction in blood pressure, however, was not found in those whose apnea was only reduced by 50% with PAP therapy. So what this means is our PAP therapy needs to reduce apneas by more than 50% in order for it to have an effect on their blood pressure. So good control of apnea is needed to improve hypertension. To add to this, not only does it need to reduce their apneas by more than 50%, but the patient needs to wear it every night. It's great to have the machine and the device, but it's not going to bring your blood pressure down if you don't actually wear it. Let's go to our next slide. Congestive heart failure and OSA. OSA actually causes a 2.38-fold increased risk for developing congestive heart failure. 11 to 37% of those with congestive heart failure have OSA, and several of those have also had central apneas. Just to review, an increase in sympathetic activity leads to hypertension, which leads to an increased risk of left ventricular stress, which leads to cardiac dysfunction, resulting in congestive heart failure. Central apnea more frequently occurs with severe CHF, and it can contribute to the progression of CHF and lead to exacerbations. Treatment of CHF, although there are a lot of other medication and lifestyle modifications needed in order to effectively treat and manage congestive heart failure, PAP therapy to treat the OSA can significantly reduce the blood pressure and reduce the workload on the left ventricle. This improves left ventricular ejection fraction and stroke volume. So it's going to improve the heart's function. This also reduces the tachycardia and frequencies of PVCs, which are encountered in some patients. Let's go to our next slide. Arrhythmias that occur with OSA. Tachycardia often occur at the end of apneic and hypopneic events, usually during the hyperpneic breathing period, meaning when the patient is trying to rapidly breathe to recover. This is often associated with an arousal. Ventricular tachycardia increases as oxygen saturations fall below 60%. So the more hypoxic a patient is, the more common they're going to experience tachycardia with their respiratory events. Bradycardia, on the other hand, actually occurs during the event, during the middle of the event. It rarely leads to sinus arrest or AV block. Nocturnal bradycardia is an indication to screen for OSA, though. Let's go on to our next slide. Now we're going to take a look at how OSA contributes to thrombus formation. It's important to recognize that thrombus formation is a very complex process, and we're not going to look at the details of how a blood clot forms in our body, because that's just going above and beyond what we need to do. But you do need to know that OSA contributes to thrombus formation throughout various routes. If you look at your diagram on the right side of your screen, you see that there's sleep-disordered breathing, meaning obstructive apneas and hypopneas. And these cause reactive oxygen species, chronic repetitive hypoxia, sympathetic stimulation, hypercapnia, sleep fragmentation, and inflammation. Each one of those ends up contributing to endothelial dysfunction. That's the inner lining of your vascular walls is the endothelium, and it can cause it to malfunction. This endothelial dysfunction caused by sleep-disordered breathing causes an increased level of vasoconstrictor forces within the vessel wall and a decreased level of vasodilator forces within the vessel wall. So overall, the muscle tone of your blood vessels is more firm and vasoconstricted. The endothelial dysfunction also leads to increased coagulability, meaning it's easier for blood clots to form, and then also cytokine growth factors. Now, each one of these contribute to the vasoconstriction of the smooth muscle and the adventitial hypertrophy and proliferation and vascular thrombosis overall. So basically, OSA causes the endothelial walls of your blood vessels to not work properly, which causes them to vasoconstrict more and make it more easy for your blood to form clots. So what does this mean for our OSA patients? Well, if you have an increased risk for clot formation or thrombus formation, then your risk for myocardial infarction is much higher, as is your stroke risk. PAP actually improves both of these because if you look back to the diagram on your right, PAP is going to reduce the reactive oxygen species, it's going to reduce the chronic repetitive hypoxia, it's going to reduce the sympathetic stimulation, it's going to reduce the hypercapnia, and it's going to reduce the sleep fragmentation, which overall should help reduce the inflammation. So all of the contributing factors to endothelial dysfunction will be removed, overall reducing the risk of clot formation, which reduces your risk of myocardial infarction and stroke. Let's go on to our next slide. OSA and metabolic syndrome. Let's start by taking a look at the diagram at the top right. See how sleep apnea causes our sleep fragmentation and our intermittent hypoxemia. Well, those two factors all lead to our sympathetic activation, the HPA axis alteration, which ends up causing an increase in cortisol level. It also increases oxidative stress. It also increases the activation of inflammation, and then it also affects leptin and our adiponectin. All of those factors contribute to insulin resistance and pancreatic B-cell dysfunction, which then leads to glucose intolerance and type 2 diabetes. So here is a direct correlation how sleep apnea is going to contribute to the development of diabetes. Okay, so going back to your left-hand column, OSA causes insulin resistance. The increased severity of OSA increases the degree of insulin resistance. Leptin, this is a chemical found in obese persons. It's actually produced by fat cells. Leptin is actually found in all people, but in increasing amounts in obese people. The reason for this is because it's produced by fat cells, and obese people have larger fat cells. Leptin increases production of platelet aggregation, which means as leptin increases, then your risk of thrombus formation increases. This also increases your risk of MI and stroke. So a patient with OSA is actually getting a double whammy of thrombus formation risk. One, from the leptin increase if the patient is obese, and then two, from the endothelial dysfunction as we talked about on our previous slide. So what does this have to do with metabolic syndrome? Well, if you look on your lower right, metabolic syndrome is where a patient has central obesity. That means they have fat deposits in their abdomen. They also have glucose intolerance and insulin resistance, hypertension, hypercholesterolemia, and blood clotting abnormalities. Well, if you take a look at what OSA causes, it does cause our insulin resistance and glucose intolerance, it causes our hypertension, and it does cause blood clotting abnormalities. So any patient who is obese and also has OSA pretty much falls into our metabolic X syndrome. Let's go on to our next slide. Okay, so we took a look at how some of the specific things cause different aspects of cardiovascular disease, and this is just an overall diagram to show how they all interrelate. So OSA and all of the things it specifically causes, such as sleep deprivation, arousals, intrathoracic pressure swings, hypoxemia, reoxygenation, and hypercapnia, all of those lead to various disease mechanisms. That's our endothelial dysfunction, the inflammation, the increased coagulability or thrombus formation, the sympathetic activation, metabolic dysregulation, that refers to your insulin resistance or your glucose intolerance, and left atrial enlargement. So all of those disease mechanisms lead to the association with the cardiovascular disease, which means it leads to hypertension, both systemic and pulmonary hypertension. Remember, pulmonary hypertension is specifically due to chronic hypoxemia, heart failure, arrhythmias, renal disease, stroke, and myocardial infarction, all of which can lead to sudden death. So this is your direct route how OSA contributes to your cardiovascular diseases. Let's go on to our next slide. Okay, so at the start of our PowerPoint, one of the statements was that there are several aspects of OSA which contribute to the development of cardiovascular disease, and we need a basic understanding of how OSA contributes to cardiovascular disease. Well, throughout this PowerPoint, I hope you have recognized all the different aspects of how OSA can contribute to the development of cardiovascular disease. Just to review, those are listed here below under the physiological alterations. These are the specific aspects of OSA which contribute to the development of cardiovascular disease. It's the chronic intermittent hypoxemia, the increased sympathetic nervous system activity, the intrathoracic pressure swings, the hypercapnia, and the sleep fragmentation. All of those cause an increase in inflammation, an increase in oxidative stress, metabolic dysfunction, insulin resistance and glucose dysregulation, weight gain, hypercoagulability, and endothelial dysfunction. All of those then contribute to systemic hypertension, atherosclerosis, diastolic dysfunction or left heart dysfunction, congestive heart failure, stroke, increased mortality and sudden death, cardiac arrhythmias, and diabetes. Let's go on to our next slide. Again, at the beginning of this PowerPoint, you saw the statement that by understanding how OSA contributes to cardiovascular disease, we can reduce its risk and better manage it with proven therapies. Well, here is a PowerPoint that shows what therapies really do have positive effects on reducing the risks of cardiovascular disease. On the left-hand side, you see that positive airway pressure will decrease hypertension. It decreases the left ventricular workload, which improves left heart function. It decreases congestive heart failure exacerbations, which improves overall heart function. It decreases arrhythmias. It decreases thrombus formation, which decreases the myocardial infarction risks and the stroke risks. It improves weight management. However, PAP has no effect on glucose tolerance.